Hi, everybody. Welcome. My name is Sophie Nathenson, and I'm very happy to be here with you today. I hope you're safe and healthy and enjoying your conference. So, I got involved in ARN through my dad, who has been a past president and has been involved in ARN for a little bit over 30 years. And while I don't have a nursing background as a kid, we always got asked this question at the dinner table: who is the most trusted profession in America? And the answer, as many of you probably know, is nurses. So while I went a little bit of a different route into population health and sociology, I always had a respect for nurses and their ability to really deeply connect with patients and understand their backstory, to be able to use themselves as a therapeutic presence in addition to implementing all of their biomedical knowledge. And when it comes to health issues today, we can use the nursing perspective, the sociological perspective, the public health perspective to really get that bigger picture perspective on health issues. Because just as there are things that we can do as individuals to stay healthy, whether that's eating right or getting enough sleep, working out, and all the rest, there are actually things that we know from research on society that keeps our communities safe and healthy and can prevent illness. And so today we're really going to bring together those perspectives, and I'll share with you the sociological population perspective when addressing not just the opioid crisis, but many of the health issues that we face in our country today. We are truly in a digital age, an information age, a globalized age where things are so interconnected. And again, just like we are connected within our bodies, and when one organ or one body part starts to fail, it can affect others. That is really how our society functions as well. When we have social problems in different areas, it really creates a domino effect impacting our collective well-being. And so in order to solve these health issues and really make an impact, it's not possible to solve them in the institution or the organization or the sector of society that we are seeing the problem. It's really important to have that big picture approach and connect the dots, have that holistic paradigm where we're considering the entire culture and how that affects health issues at the individual level. And when it comes to actually trying to implement ideas and interventions on health issues, it's like planting seeds in a garden. You want the soil to be fertile, healthy, so that that seed can take root. And that soil is really like our society, and the seeds are those good ideas. And if the soil and our society is really not equipped to handle those good ideas because we lack those foundational elements of societal health, it becomes a barrier to really gain steam when it comes to those interventions. So today we will talk about that holistic approach, and I hope you'll enjoy this slightly different perspective. So again, I am a medical sociologist. I teach at Oregon Tech in the Population Health Management program and also in our master's program in allied health. And I also have spent the past 7-8 years in communities working with coalitions on health issues. So really at the end of the day, I'm kind of a perspective coach. And part of this work is really working across sectors, collecting data on health issues, and really drilling down into root causes so that when we do engage interventions and try to make changes to solve these health problems, we can do so where we're aligned with the public's health. So today, a couple of learning outcomes for you. Number one, we're just going to take a broad overview of the opioid crisis. Opioids are not my direct area of expertise, and so we're really going to focus on the context and just generally how did we get here. And a big part of this conversation in looking at research, not just from biomedical fields, but from sociology and public health, economics, when you really look holistically at the research, you see that it's such a non-linear relationship when we look at the factors in the opioid crisis. So we're going to look at some of those relationships and consider a non-vector model when it comes to taking that research and putting it into practice, making an impact. We will identify several societal level contributing factors, and part of this is just understanding the sociological perspective and taking a look at data. Even briefly, we notice that there are hotspots where addiction and overdose seems to flare up. And so when we have those geographical hotspots, it's a red flag to look at some of those community level, society level factors, because clearly there's some kind of difference from place to place, from culture to culture, that may help us understand the problem a little bit further. So this is all going to lead toward envisioning a holistic approach to addressing the opioid crisis. And I really want to emphasize, as is the case in many issues that we're facing today, with such rapid social change, and as we become more aware of how complex these issues are and how far outside the hospital we would have to go to really address the root causes of these issues, it can feel very overwhelming. It can feel like these problems are not solvable, but I'm here to tell you, you have everything you need to make a contribution to this problem, because all you need is you. A lot of these problems really stem from our society, our minds, and those slight perspective shifts can really make a huge difference in your patient's life. And it can make a difference really as an entire culture, as we broaden out our perspective and we consider, rather than looking at pain and pain treatment when it comes to understanding the opioid crisis, thinking about suffering and compassion, and really getting outside our day-to-day stress where we see these issues, and outside our personal issues where most of us know someone or have a friend of a friend who has suffered or even died from opioid addiction. Taking that step back, having that slight paradigm shift of seeing this whole big picture, that can actually help reduce the stigma and some of the blocks to really having a more compassionate approach that will ultimately make the biggest impact on the issue. So a lot of stuff is going to come up. Feel free to take notes. And while we don't have a live Q&A, I'm happy to meet with individuals or groups to talk about strategies to combat the opioid crisis and just have a discussion in general. So this crisis has been declared a public health emergency by President Trump. And when we talk about the opioid crisis, we're talking about a lot of different things. We're talking about the abuse of prescription drugs, also non-prescription drugs, as well as illegal drugs that are derived from opium. Where we're at right now, we are in the deadliest drug crisis in history. We have really unprecedented levels of not only overdose, but use and misuse. So the scope of the problem is getting so big. And when we compare society to society, for example, the United States with some European countries, we see that there's something about America that really stands out as far as what this problem looks like here. And so part of having that sociological perspective and comparing society to society is understanding what those societal factors may be, and so what solutions would really look like from society to society. And this is not unlike the coronavirus pandemic, where it's affecting countries in different ways. It's also highlighting a lot of the underlying issues socially, economically, psychologically, and it's highlighting the healthcare system's inability to really address the full picture of the roots of those crises. Our healthcare systems since it's not a unified system, but we have kind of a fragmented set of systems, it's not necessarily equipped to fully engage in a public health perspective. And our policies around issues like the opioid crisis are also not aligned with public health priorities. So when we see that America represents 4% of the world's population with 27% of the drug overdose deaths, again, it's a red flag, it's a pointing finger to try to understand what some of those underlying root factors are and why we struggle with this crisis really the most of any other country. Now, the crisis has gotten worse from 72,000 overdose deaths in 2017, which was a 5-fold increase from 1999. We see that this problem is getting worse and worse. And ironically, we're also hearing more and more about how it is a crisis. So what's the disconnect between being aware that the problem exists and not being able to fully execute on potential solutions? So again, just a really brief overview. You can check out this infographic. I'll talk more later about the idea of the tip of the iceberg and how this crisis and looking at overdoses is really, it's kind of like a symptom of a deeper problem. And it's also really a fraction of the total suffering that surrounds overdoses. It is an emergency situation right now. We are at the emergency phase. So part of the solution is really ramping up treatment and being able to engage those emergency solutions. But when you see how prevalent misuse is, we're over 10 million people, that is really alarming. And it goes to show that while efforts to deal with the emergency situations are absolutely necessary and absolutely need to be ramped up, there's such a huge backstory to this that there are many other ways that we can address the underlying situation. So we'll talk about that further in this presentation as we consider why us. Now, I'm sure a lot of you have initial ideas, intuitions, and based on things that you've read and understood about why this is such a problem in America. But just to kind of reiterate, we consume almost 100% of hydrocodone, over 80% of oxycodone. And again, with comparing society to society, it can be very enlightening because we do have high prevalence of pain and of chronic pain. We have issues with obesity, aging. We have issues with social problems that cause stress, and that stress response relates to pain. So yes, we do have high levels of pain. That could be part of why we consume so many pain medications. But compared to countries like France and Italy that have similar levels, as we know, Italy also has an aging population. They've got similar levels of chronic pain, but we have about 6 to 8 times the consumption of pain medication. So that starts to, again, point the way to really considering some of these societal level factors. It's not to say that there aren't major genetic, individual, psychological factors in addiction and with the opioid crisis as a whole. So this is not a debate of which set of factors is even more powerful. This is just a presentation of some of those bigger picture factors. What we know from fields like psychoneuroimmunology is that not only are these health issues extremely multifactorial, but these sets of factors affect each other. The field of epigenetics is another field that really demonstrates this. The fact that our environment and our genes not only both play a part but reflexively affect each other is really important if we are even beginning to think about trying to alleviate the pain and suffering caused not only by the underlying pain and the social conditions, but the pain that results from addiction and overdoses and how that affects families and communities. So this perspective it's really important to really just get the full picture and take a step back to see where we want to put our efforts and where we might be wasting our time and energy, quite frankly, with things that will not take hold because of other factors impeding those solutions. So one of the many non-linear relationships is this relationship between prescription drugs and abuse of prescription drugs and abuse of illicit and legal drugs. While it is very clear that prescription drugs absolutely can be a gateway drug, whether that is from an individual's prescription or whether somebody that didn't have a prescription that's getting it from family and friends. When it comes to opioids, they are very prevalent and available via social channels. That means family and friends and dealers. There's actually almost an equal distribution of this drug through legal and biomedical and social channels. So that's huge. That's really, that availability is a large factor. Diversion and recreational use, that happens relatively easily. When you look especially at rural areas, for example, which don't represent the majority of where overdoses are happening, but it's alarming because of the lower population and what we see in rural areas. A lot of times providers may prescribe a lot more of a medication than probably is needed, because when you're driving long distances in a rural area, it may not be convenient to pick up multiple prescriptions. So little things like that can cause more of an abundance of unused medications. And that is partly contributing to this phenomena of social channels being very important for this availability variable. Lots of studies have examined the relationship between prescription and non-prescription. Researchers have found that heroin users, up to 75%, had already used some kind of pain medication. There are other studies that show people that are seeking treatment for heroin maybe did not start with prescriptions. So it's not a one-to-one relationship here, but this is all just kind of pouring gasoline on the fire, where we have pain medications, we've got heroin available, we've got the synthetic, the fentanyl that is being laced with things. That is all driving, especially the overdose issue. So how did this even happen? Again, you intuitively or through what you've been exposed to, you kind of know some of the big trends that have happened in America and just the way that our systems are set up and the influence of companies. This really, part of the root cause of this is quite simply downplaying or providing misinformation about the addictive qualities of opioids. And it's interesting to kind of take a baseline today, how that has changed. We really need much more of a strong shift providing education on just how addictive these medications are. Because historically, this has been downplayed, ignored, or even flat out, health providers have been told that it's not a problem. This, combined with the acknowledgement, the idea of pain as the fifth vital sign, so starting to really take it seriously, trying to measure pain. And pain is such a mysterious thing, because one of the few things that we cannot really objectively measure in healthcare is pain. It is something that by definition is measured subjectively. And so you have more awareness of pain, there was a concern that pain in America was not being addressed fully. Then add to that marketing and education on these pharmaceutical solutions that were touted as not being addictive. So then you have the concept of overprescribing and patients expecting that. And really part of this gets down to the provider-patient interaction and communication. And so when we think about changing the paradigm and integrating potentially non-pharmacological approaches, for example, the idea that the patient wants the pharmaceutical intervention, if we truly get down to a public health, social well-being model where we care about the patient's overall trajectory of suffering, it would be important to integrate resources on addiction treatment and non-pharmacological approaches. And if there's this barrier that the patient is not going to want that, one of the factors that you can be a part of is creating that healthy communication and close relationship with the patient to be able to integrate those other ideas. Policy-wise, insurance coverage, the declining coverage from insurance on behavioral therapies and pain management, all of these factors pushed pharmaceuticals really to the #1 spot in terms of treating pain. So to reiterate and bring it back to this idea of the population perspective. A population can be a patient population, it can be a neighborhood, it can be a school of students, it could be employees at a business, it can be a city, a state, a country. When we look at populations, it's different, but not dissimilar to looking at an individual person's health, because we are still using many of the same health indicators and metrics and data points. It's just that we're looking at the population as a whole. And so when we look at the population's health as a whole, while it is a collection of individual behaviors and individual people, there are certain patterns that emerge when you look at the entire population's health. And those societal factors, the sociological perspective is really about what aspects of our social systems and how we are organized as a society, how do those factors relate to health as a manifestation of those social factors? So medical sociology in an academic sense is really about society. It's about looking at the health of a society for the sole purpose of understanding that society better and advance sociological theories. Flipping that, looking at society as a precursor to health issues gets more into the population health perspective. So both work very well together to understand a population's health. Where we're at in terms of healthcare evolving as a system, medical sociology originated really in studying healthcare as its own society. That's really the roots of that discipline, is looking at the healthcare system as a social system. And so analyzing that social system now, because of more regulations and changes in financing models and the shift from fee for service to episodic care, the creation of coordinated care organizations, all of those things are creating pressure to not only treat people when they're sick, but keep people healthy and out of the hospital. And one of the challenges of that is if you want to keep people healthy and out of the hospital, that work happens outside the hospital. So what can you do as a health professional to build bridges from the hospital to the community? And how can that awareness of that bigger backstory affect how you interact with patients one-on-one? So this population perspective ultimately does trickle down to your perspective and how you can foster a better provider-patient communication style and relationship. And additionally, how you could potentially get involved in things that are really partially driving this issue. And ultimately, healthcare organizations will have to learn new tools, new ways of doing things that are more holistic and are more geared towards our collective wellness, because our healthcare systems are not fully equipped to really deal with just the symptom management of all of the health issues that we have. And in the pandemic, with coronavirus putting so much pressure on particularly our vulnerable populations that suffer from chronic illnesses, and those conditions of vulnerability add on coronavirus, not only do we have rising death rates now, but we have this situation where our systems are not equipped to both deal with emergency situations and engage in these more wellness, population health related practices. So it's going to require resources in addition to the perspective shift. And part of understanding how all of these variables interact with each other is, where should we put resources the farthest upstream to ultimately save lives and save money in the long run. So we need this combination of an emergency approach and really playing the long game. And so the phrase upstream factors refers to things that can be done very early on before illness manifests. So upstream factors in something like the opioid epidemic, those can be things like political instability, economic downturn, issues with physical infrastructure in society, the stigma around addiction, policies, federal policies, economic policies, healthcare policies, educational policies. That is far upstream. Midstream, you're dealing with harm reduction and treatment, and downstream, the absolute emergency situations, preventing an overdose in a moment. So research on social factors and demographic factors helps us kind of understand that these societal factors exist in the first place. And so looking at country variation we talked about, but state variation. Any time that there's variation, we know that there are social factors at play. If the rates of illness are the exact same everywhere, then we would be less inclined to even engage with the idea of social factors. So, such a huge spectrum. My home state of Nebraska with the lowest overdose rate, all the way up to West Virginia with the highest. Humongous variation there, which tells us something. We have different social groups. In sociology, we often compare social groups. It's not to stereotype, it's not to put people in a box. It's to be able to look at things like gender, race, age, and again, what we're trying to determine is not that people that share social factors are similar. It's to determine if there's a major statistical difference between different groups in society that's telling us something about society. It's telling us something about the social conditions. And so women, actually from 40 to 64, are one of the fastest growing groups as far as being negatively impacted by the opioid crisis through overdoses and addiction issues. This is a disproportionate issue affecting white people. Theories around that really center on potential racial and cultural bias to not prescribe to folks that we may have a perception of being higher risk for addiction issues by stereotyping. Then you have folks that have mental, emotional, physical ailments, injuries. This issue also disproportionately affects groups that have jobs that are very hazardous, that can cause injuries. And then you have this concept of deaths of despair, where this is kind of akin to suicide. or dying from alcoholism, where there's these underlying social conditions, stress, again, economic hardship. When you have a community that has jobs coming from one industry and that industry collapses, and all of a sudden families have to completely switch it up and do something totally different, and that feeling of instability, even if you have economic security, that social stress affects our cortisol levels, it affects our stress response, it affects our physical pain, our mental pain, it affects addiction, risk, and it affects overdoses. The strategy to have a war on anything can be potentially problematic, as it can end up being a war on the people themselves. The war on drugs did not significantly reduce the availability or access to street drugs. What it did was it contributed to this stigma around addiction, that it is a moral failing, it is a crime. And so this is part of our history in what we've tried as far as really trying to address this issue and the suffering that it causes. It's not to say that there aren't elements of these types of policies that could potentially work, but we really have to understand the impact on communities that these policies had, in addition to the impact on individuals. And so looking at this problem and facing the really harsh and uncomfortable reality that the problem was actually getting worse, even though our awareness is potentially getting better, we have to think about, how can we go upstream? How are we supposed to think about broader societal conditions that, like I said at the beginning, can be very overwhelming? It can make us feel really small, like we can't do anything. Or if we can't control, national politics, that can make us feel very powerless. Part of the solution is the perspective shift, though. That is part of it. The studies of Rat Park, if you've heard of Bruce Alexander's work, looking at and conducting these experiments with rats where they may be isolated in a cage and they may have, a morphine-laced water bottle and regular water and sugar water, and they're choosing the morphine, and then you expand that cage to a huge area with lots of places to play, other rats to interact with, you've got food is plentiful, places to exercise, and the percentage of rats that even choose to use, let alone abuse, the drug-laced substances goes way, 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 way down. And there is evidence in the public health, medical sociology, epidemiological literature that humans are not dissimilar to that. Even though there are individual factors and genetic, biological factors in addiction, absolutely. Again, when we look at population versus population versus population, there is something to be said about the social and environmental conditions playing a role in, like we talked about, that huge variation from place to place. So that is really part of this new paradigm. We're also thinking about social problems as contributing factors, also as consequences to the opioid crisis. And many of the social problems that are contributors, not just to the opioid crisis, but literally to almost any other health metric that we could measure at the population level. One of the, possibly the most influential factor is inequality for many, many health issues. And there's lots of great research on that, using lots of data points from many, many countries. There's something about having large gaps between rich and poor, gaps between blacks and whites, gaps between educated less educated. There's something about that that seems to negatively impact everyone. And so things like poverty, racism, access to services, the stigma, how we even view this problem, our social stress, those are huge contributors to this issue. And again, we balance this feeling of being overwhelmed because it's so big, but also look at a lot of these issues. There are things that we can do as individuals in our one-on-one interactions, practicing kindness, compassion, understanding, that actually would move the needle because of such a psychosocial slant to all of these root causes. So solutions are at different levels. Part of our individual journey is to find ourselves in the grand scheme of things. We can only do what we can do, right? So you find yourself where you're at and what you can do and what your role is. Your role may not be federal policy. Your role may be as an educator. Your role may be as a family member. It may be as a nurse. You may be tasked with developing a harm reduction program. All of these levels are important. And really, it doesn't matter which one you fall into. It just matters that you feel connected to a solution if you feel the call to be a part of the solution. If this is overwhelming you, a great antidote to that is being part of a solution. So you've got primary prevention, that's really far upstream, like we talked about, secondary prevention, harm reduction, tertiary prevention. You've got those evidence-based interventions, treatment, emergency situations, but also empathy and caring. Probably the worst thing that you can do, according to research, is simply not treat the patient that seems to have addiction issues. That is one of the most harmful things you can do next to putting that person in jail, socially isolating them or abusing them. So even that perspective shift around stigma and how you're interacting with someone can make a difference. It's kind of like if somebody is really treating you bad and they're giving you a hard time and you're really frustrated with them, and then you get some knowledge that they had a death in the family very recently. You can't bring that person back. You can't counsel that person who lost the loved one, but there's going to be a subtle or maybe even a dramatic change in the energy you bring to that person and how you're interacting with that person now that you know that backstory. So when we get into the backstory of individual patients and the backstory of society, there is something you can do about that, because the awareness and the understanding of the backstory can affect our one-on-one interactions, even if you can't address any part of the backstory, even if you have absolutely no control over any of those underlying factors. You still can make a difference in those one-on-one interactions with that knowledge and awareness. So the public health approach is obviously it's looking at collective well-being. It's looking at the health of the public. So it is a population perspective. The public health approach is pretty holistic in that, like this diagram shows from the CDC, it puts all of the types of interventions on a spectrum, of course, addressing the most foundational elements of our society and the health of our communities. That's social, that's economic, that's our base. Then we have changing the context, changing our perspectives. Then we have the longer lasting interventions, educational approaches combined with social supports for lasting change. And then you have clinical interventions, and then the one-on-one counseling and education. So this is not to say that counseling and education is the least important. It's really, rather than thinking about it as smallest impact, largest impact, you can think about it as the large population or the country as a whole all the way up to that individual person. And if you can help one person, that's enough. That's huge. So who's to say that's not a big impact? But anyway, you can kind of see how this paradigm works and how much it relies on partnerships, because the stuff is so outside the hospital bounds, for example. So an ecological model, this is stemming from a public health approach, will look at drug use behaviors and the context as pretty heavily influenced by not only the supply and the availability of the drug, but also these structural factors. And again, part of the solution is really expanding education on structural factors. Just like we have in healthcare and in public health, this idea of cultural competency and how important that is, there's also the concept of structural competency. And just that knowledge and awareness of how employment opportunities and education and material deprivation and inequality and residential segregation and racism, how those are actually playing into the gravity of the situation with the opioid crisis now, just that knowledge and awareness, it starts to shift where we put our time, energy, and resources in the solution. Does make a difference. And all of that, this is flowing towards the health outcomes. The health outcomes are, that's the emergency alarm bells going off. And the overdose issue needs to be addressed. This concept is that there's multi levels that can all be addressed. Not by the same person, not by the same entity, but they're all a part of the puzzle. And speaking of parts of the puzzle, data is really huge too. Not just data on, for example, how many overdoses, but what types of data do we have on these social determinants? What types of data do we have on folks that are not even in the biomedical system and are using street drugs? How much information do we really have on them? And can we trust that information that we get from surveys or interviews? And how do we make that data better and more available? Or even if in a perfect world we had awesome data in hospitals, how do we link that data with data from the criminal justice system or public health data or data from within the schools? If you're trying an approach where you're trying to prevent opioid addiction in teenagers, for example, what data do you have on them? So this slide is just showing all of the different data points that are very commonly used in describing this issue and the limitations of that data. And it doesn't mean that it's totally bad data and that we can't use it. We can and we do. It just means that part of understanding all of these interconnections is getting better data so that we actually can view this problem. And coming from a standpoint of, working in communities and working in different coalitions and groups and interacting with people across political lines, one thing I always like to impart is that you would really be surprised how misleading, in national media, creating this idea that everything's polarized and everybody's us versus them. When it comes to local communities, there's far more alignment than not in things like keeping our children safe and healthy or alleviating suffering. That's a big part of a whole paradigm shift in America in the current political and economic and social situation that we're in. And data can be very powerful to start a conversation and to really drill down on the fact that whatever your political ideas are, whatever strategy you may be advocating for or attached to, the bottom line of trying to reduce deaths and having the metrics that we need to learn more about the issue can be a great way to start a conversation, especially locally. where you can get some alignment. Geographic information systems is really big in the data world and in the public health, sociological population paradigm, because it shows us those geographic hotspots, which really helps make that perspective shift, that there's something about the places that we live and the communities that we live that play a part in health issues. So it's a great visual. And states like Rhode Island that have started to incorporate better data systems and tools to understand the opioid epidemic, very helpful to be able to just gather around the computer screen and look at these hotspots and what we know about those communities, and then how we can engage those communities. So public health strategies are definitely multifaceted. Public health, more so than traditional healthcare, is already all about engaging across sectors in the community. So healthcare and public health can learn a lot from each other. Public health strategies encompass, of course, data. This needs to be supported by legislation. Safer prescribing is a part of it, but take a look at all of these things, including stigma, harm reduction, expanding treatment, regulatory changes, criminal justice reform, all of those strategies. When you envision your own contribution as a health professional, and maybe you zero in on safer prescribing because that's something that happens inside the hospital, but really this issue is so much bigger. And so this is what it looks like to start building a strategy that is also bigger. And this kind of infographic on this slide is from the CDC. This is specifically targeting workplaces. So a lot of these strategies can zero in on a specific place, maybe a workplace or a school, and create a structure for the work that can be done to provide education, provide resources, to reduce the risk of addiction, to treat folks that are suffering from addiction, and to really start to curb this issue and move the needle. And so this is a complete partnership approach. It's not possible to do this without the help of government, schools, police, emergency services, social services, but also you. Again, risking being overly repetitive, the gravity of the situation and how many people, quote unquote, should be involved doesn't mean that you can't make a difference today. You don't need to wait until your local officials are hip to what to invest in to create a healthier community. You don't have to wait until your school becomes aware of this issue and starts engaging in education. But some of the most successful communities do have this cross-sector collaboration, and it takes time and it takes a culture change. So to review, this is not what has been called a vector model or kind of a linear model. It's not purely based on availability. Again, even if we use rat park experiments as a metaphor, curbing the availability of the drug, it's not a one-to-one ratio of reducing availability and reducing overdoses. In fact, the exact opposite has happened. And that doesn't mean it's not important to curb availability if that's a variable. It means that all of these variables exist in the petri dish of our culture. And so addressing one single variable may not have an impact. That doesn't mean the variable is not important. It means that there are other variables and they're also intertwined with each other. And that petri dish is our social conditions. And when we're stressed, when we have a pandemic going on, when our economy is shaky, when there's so much unpredictable stuff going on, that is creating a certain environment. And at the same time, because we know how much awareness is important, it's actually, even though on the surface it looks like, how can we do anything in this time period because things are so whack? But actually, this is a great time to do stuff. It's a great time to try to make an impact because the level of awareness of the relationship between society and health has never been higher. And we're talking on a complete global scale and the very most local scale, like in your own family, in your own home. So thinking about that relationship between culture and society, it is actually the time to engage. So we know societal factors like, again, the types of jobs people are doing and have access to. Those high risk jobs are real red flags for a community. If you've got a community that the biggest employment opportunity is a job that's very physically hazardous, that's a red flag. Stress having to do with our environment, previous substance abuse, a culture of substance abuse, that's a red flag. Understanding the relationship between incarceration, our tolerance, and overdose, that's something to really examine. And so although we don't always have the data, these are some of the things that you can start to look to in your own local community to try to connect the dots of how we got here and how to get out of this. Because the number of people that are suffering from this is growing every day. I mean, it's just continuing on. And we have successes here and there, but this concept of diseases of despair is something that is worth looking at and really being reflective of. When we see the research on structural factors like poverty, like lack of opportunity, like bad working and living conditions, like racism, and the impact on health, on overdoses, on addiction, suicide, mental health, we see that there's a relationship there. We start to see how much we can actually make an impact on our collective well-being if such factors are addressed. And there is really a national call for these issues to be addressed. And so this is something to really tune into and to find those places and those people that are engaging in the addressing of structural factors and social factors, because people are doing it. May not come on the news every night, but there are organizations in every single community working on every single one of those structural factors right now as we speak. They may be getting paid for it, they may not be. So how can we really redirect the billions upon billions of dollars that is spent on the opioid problem? Redirect maybe just a couple million, maybe a couple million, maybe a couple billion. If we redirect that further upstream and consider things like economic policy as opioid addiction policy and really create that new paradigm, we will see not only a positive impact in terms of things like overdoses, but the strategies and the projects and the programs that people are already engaging in will have more of a chance to be successful. Because like we said before, something about inequality, particularly economic inequality, but it's a social condition too, and it's a psychological condition, and it's about how we treat each other. Something about that erodes well-being, not just for the disadvantaged, although marginalized populations are by far more affected, but the opioid crisis is interesting in that it's affecting white people. It's kind of a reversal of this because of that potential stereotyping and white people being more likely to get those prescriptions. They're now disproportionately affected as well. So it's not to ignore the inequalities in the marginalized populations, but when it comes to the opioid crisis and when it comes to deeper inequities, it's really something that truly does affect everyone. And that's part of where our culture is at today, isn't it, with the coronavirus pandemic, and how apparent it is that public health affects everyone, and that it's not like we can shut the door on one problem because we're not affected by it. We are all very acutely aware of how affected we all are with these problems. So coming back to the nurse's role, the most trusted profession, the therapeutic presence, the person that has so much biomedical knowledge, and in most cases, I would say that's coupled with a very deep understanding of the patient experience. Who knows what's going on most with the patient other than their family? How can you be that therapeutic presence? When it comes to perspective shift, it's really not about getting new opinions. It's not about releasing your opinions. And it's not even about getting a new perspective for you. It's about being able to see suffering, and not to be overly focused on pain and treatment, but to really see suffering, acknowledge suffering, and be able to, through your own mindfulness, your own self-care, your own stress management, involvement in the community, involvement in your family, being educated on non-pharmacological interventions. What is the highest likelihood of actually impacting someone that could be very adversely impacted by the opioid crisis? Where's the highest likelihood? What strategy? And one of the strategies that has the highest likelihood of making an impact is simply how you interact with your patient. Anything that you want to add, like education or making a linkage to treatment or feeling a resistance to wanting to prescribe if somebody may be at risk, like anything that you want to do to play a role in this health crisis, your effectiveness will increase with your relationship with the patient. And being able to understand all the factors and the reasons people may be in a situation where they're abusing drugs helps navigate the feelings and the perceptions that come up that can actually be barriers in someone getting help. As I said, researchers have noted that one of the most harmful things would be to actually not treat or disengage with someone that is at high risk for addiction. That's when you double down on your care and compassion and those strategies. So lots of ideas. There's no shortage of good ideas when it comes to a lot of different health issues, but they range from big to small. You may be involved in creating a data collection tool, and this doesn't have to be fancy software or using GIS, although it can be. It doesn't have to be related to electronic medical records. It could be just a survey of your patients in order to learn more about that backstory. You could be an advocate for more equitable economic development. In many of our communities, the awareness that structural racism exists and that it's harming the fabric of our society, economics comes into the conversation, and there are things that you can do. There are people that you can vote for where you may be able to contribute to expanding the opportunities for thriving economically across different social groups. You may engage in a training that has more to do with empathy and compassion than really understanding the pharmaceutical angles of this issue. You may feel called to engage others in this type of thing and to really look into the research on how your therapeutic presence can influence patient adherence. You can get to know the folks in your community that are addressing the issue from different angles. Where are the treatment centers? Do you know anyone that maybe works at a treatment center? Are you aware of groups or apps or Zoom links to online meetings? Anything that may come into play. And again, as the most trusted profession, being able to hear from you, hey, I have a friend of a friend that goes to this meeting. It seems to help them. Like, maybe it'll help you. Who knows? Having that type of a open, honest relationship with your patient may literally be the difference between life and death. And that's what we're dealing with here. It really does make a difference. So there are a lot of different references and further reading. There's all sorts of stuff online that you can read up on. So I encourage you to take a deeper dive into some of this research. And for me, my time is up. That wraps up this presentation. I really hope you got something out of it. I really thank you for all of your service on the day-to-day, to yourself, to your patients, to your families, your communities. It really does make a difference. All of the research and understanding that we can get on society as a whole ultimately trickles down to how we treat one another and how we approach these types of issues, and being able to make the conscious choice from punishment to a compassionate, holistic approach that really, from a rational perspective, addresses the root foundational issues that are really affecting this crisis. So with that, I will let you go back to your conference and check out some other talks. And again, thank you so much. It was really an honor to be here, and I hope you have a great day.